Hello, everyone, and welcome. I'm Annette Stanton, and I have the honor of serving as chair of the Department of Psychology here at UCLA. As we know, traumatic experiences are all too common. In today's conversation with two professors of health and clinical psychology, we will learn about the potential consequences of trauma for psychological and physical health, and how we can intervene to offset these effects. Following their conversation, we look forward to taking questions from you, which you can submit through the Q&A function at the bottom of your screen. Please feel free to submit your questions at any time, and note that the chat function is turned off. Especially for those of you who are new to our Psychology Presents series, I'd like to first share a bit about our department. As many of you know, we're a leading department of psychology and education in the nation and the world. We have foremost experts in psychology and neuroscience who conduct innovative and impactful research in behavioral neuroscience, cognitive, clinical, developmental, health, quantitative, and social psychology. As of a couple of weeks ago, we have exactly 4,544 undergraduate students in our 3 psychology majors, and our highly competitive Ph.D. program with 216 graduate students now supports tomorrow's leaders in research, teaching, and public service. You all know that one of my favorite activities as chair is highlighting the important research of our faculty members and our students. And tonight's event marks the 8th in our Psychology Presents series, with a focus on the topic of the impact of traumatic stress, understanding implications for health and treatment. This evening, 2 of our esteemed professors will talk with each other about their research findings and implications, and then I'll join them to pose your questions. Now, it's my great pleasure to introduce 2 superb faculty members. Last spring, they collaborated to teach a course on trauma and health for our PhD students, and I would love to sit in on that course. Dr. Lauren Ng is assistant professor of clinical psychology and leads the Trust Lab, which stands for Treatment and Research for the Underserved with Stress and Trauma in our department. Dr. Ng's research focuses on translational science as applied to developing, culturally adapting, and implementing evidence-based interventions for underserved, minoritized communities, both domestically and internationally, who have been affected by trauma. Recently, she's been investigating the effectiveness and implementation of treatment for post-traumatic stress disorder, PTSD, both here in the US and also in Rwanda and Ethiopia. Dr. Ng has earned national and local awards for excellence in mentoring students, and in November, she'll receive the International Society for Traumatic Stress Studies Award for Excellence in Trauma Services for the Underserved, Policy, Advocacy, Research, and Clinical. Congratulations, Dr. Ng. Dr. Jennifer Sumner is Assistant Professor of Health and Clinical Psychology. Dr. Sumner's research lies at the intersection of the psychological and physical health consequences of trauma exposure. Specifically, she focuses on elucidating the biopsychosocial mechanisms linking stress and trauma with disease risk, with a particular focus on cardiovascular disease, the leading cause of death worldwide. Dr. Sumner heads the Sumner Stress Lab, which examines how the experiences of stress and trauma and particular aspects of PTSD relate to accelerated aging and risk for chronic disease. Her lab aims to use this knowledge to develop targeted interventions to offset risk for adverse health outcomes. Dr. Sumner also has earned awards, in this case for her early career scientific contributions from the Society of Health Psychology of the American Psychological Association, the American Psychosomatic Society, and the Association for Psychological Science. Welcome, Dr. Sumner, and take it away, professors.
Great. Well, thank you so much, Dr. Stanton, for that lovely introduction. I'm going to go ahead and share my screen. So thank you. It really is such a pleasure to be a part of this UCLA Psychology Presents event this evening. And I really am so happy to be able to engage in this discussion tonight with my colleague, Dr. Lauren Ng, who you just heard introduced. I feel really fortunate not only to be a member of the psychology department here at UCLA, but to also have in Dr. Ng a colleague who's also truly committed to improving the lives of individuals after trauma. And together, we're both so delighted to be able to have you all here with us this evening. So I'm going to be kicking off our discussion tonight, thinking about the impact of traumatic stress. And I'm going to start by focusing on trauma. What is it and how can it impact our health? So what we see is that trauma is common. The vast majority of individuals, so between 50 to nearly 90% of individuals, will experience at least one traumatic event during their lifetime. And when people hear about trauma, often what first comes to mind is an image like this, the idea that trauma is something that soldiers encounter in a combat setting. And combat-related experiences can certainly be traumatic in nature, but this is not the only context in which trauma is possible. And what we see is that traumatic experiences really are wide-ranging in nature. So they can include something like combat exposure, but they can also include experiencing a natural disaster, childhood abuse, unwanted sexual contact, physical assault, a serious car accident, intimate partner violence, as well as the violent or accidental death of a loved one. We also see that global events, such as the COVID-19 pandemic, can impact individuals in a number of different ways. And for sure, the past few years really have been very stressful times for many. And it's possible that certain experiences related to COVID-19, so for example, experiencing extreme respiratory distress as a result of COVID, or treating severely ill patients as a first responder or healthcare professional, these experiences could all be potentially traumatic in nature. And although we see that trauma is common, many individuals really are resilient after going through these types of experiences. But nevertheless, a sizable proportion go on to experience emotional difficulties, and we see that trauma can affect individuals' mental health in a number of different ways. And so one of these ways is by triggering the onset of post-traumatic stress disorder, or PTSD. And this is often referred to as the quintessential trauma-related mental disorder, in that it can only be diagnosed after experiencing a traumatic event. Symptoms of PTSD include re-experiencing of the traumatic event. So for example, having thoughts about the event that come into your mind when you don't want them to, or having nightmares about the trauma. Avoidance of trauma reminders, so trying not to think about the trauma or avoiding places that remind you of the event. It's also characterized by negative changes in thoughts and feelings. So for example, just thinking that the world is an entirely dangerous place, or feeling like you lose interest or pleasure in things you used to enjoy. It's also characterized by symptoms of physiological hyperarousal. So for example, being hypervigilant on the alert for danger or startling easily. And these symptoms need to last for at least 1 month after a trauma in order for a diagnosis of PTSD to be given. But we also see that trauma can affect mental health in other ways too. For example, it can trigger the onset of depression, anxiety, as well as the misuse of alcohol and drugs. But importantly, the impact of trauma doesn't just end with the mind. We see that trauma can also have important implications for physical health. And indeed, there was a study done as part of the World Mental Health Surveys. This was an investigation conducted across 14 different countries. And here they found that greater exposure to traumatic events was linked to the onset of a number of physical health conditions, including arthritis, back pain, asthma, lung disease, diabetes, ulcer, headaches, hypertension, and heart attack. And so the research that I do with my students here at UCLA really aims to understand just how that works. So how does trauma affect our physical health? And so now I'd like to tell you a little bit about my research in this area by focusing in particular on heart health after trauma in women. And when it comes to heart health, cardiovascular disease encompasses a group of disorders of the heart and blood vessels. And as we heard from Dr. Stanton earlier, it's the leading cause of death and disability in the United States as well as worldwide. So it's estimated that on average, someone dies of CVD in the United States every 36 seconds. We also see that CVD claims more lives each year than cancer and chronic lower respiratory disease combined. CVD is also costly. So in the US, direct medical costs of CVD, as well as indirect costs due to lost productivity, they were estimated at a staggering $378 billion, and this was just for the 2017 to 2018 year. Importantly, though, approximately 80% of CVD events are preventable. So it's really important for us to be able to identify modifiable factors that can help to promote our cardiovascular health and help to try to prevent the onset of cardiovascular disease. So you might be wondering, why exactly adopt a women's health focus in the work that I do? Well, the vast majority of research on trauma, PTSD, and cardiovascular outcomes has been conducted in predominantly male samples of veterans. And there's a number of reasons why it's really important to study the links between trauma, PTSD, and cardiovascular outcomes, specifically in women. So for one, PTSD is twice as common in women than in men. It's estimated that approximately 1 in 10 women will develop PTSD in their lifetime, as opposed to 1 in 20 men. We also see that PTSD is more chronic, severe, and impairing in women than in men. And not only is PTSD more common and impairing in women than in men, but we also see that there are sex differences in cardiovascular disease as well. So for example, symptoms of cardiovascular disease can differ for women and men. As just one example, women, when experiencing a heart attack, they may present with symptoms like dizziness or nausea, rather than, say, pain in the left arm. We also see that certain CVD risk factors are either unique to or more potent in women than in men. So for example, hypertension during pregnancy, this is a CVD risk factor that's unique to or only possible in women. And in addition, factors like smoking and diabetes, although linked to cardiovascular risk in both women and men, we see that they're more strongly predictive of the onset of cardiovascular disease in women. And so even though there's this awareness of these sex differences in cardiovascular disease and attempts to offset these outcomes, we see that rates of high blood pressure and CVD have been rising in women in more recent years, and particularly in younger women. And here we're talking about women as young as ages 35 to 55 years. And so in the work that I do, we've been able to examine the extent to which trauma and PTSD are linked to a wide range of cardiovascular outcomes, specifically in women. And we've been looking at things like traditional cardiovascular risk factors like hypertension, to acute CVD events like having a heart attack or a stroke, to even more rare cardiovascular events like venous thromboembolism, which involves developing a blood clot in your veins. And we've been able to explore these questions in large samples of both women living in the community as well as women veterans. And so across these studies, we found that women with PTSD were more likely to develop hypertension, heart attack, stroke, and venous thromboembolism compared to women without PTSD. So here we see that a psychological response to trauma, namely PTSD, was linked to developing cardiovascular events. Additionally, we found that even women with trauma alone who didn't go on to develop PTSD, they were more likely to experience cardiovascular events compared to women who didn't have any trauma exposure. So this effect size wasn't as large as what was observed for women with PTSD, but nevertheless, even if women had just experienced trauma without developing PTSD, they still showed to some degree an elevated cardiovascular risk compared to women who had not experienced any trauma at all. And so we've been interested in trying to figure out what may be some of these factors that link PTSD with risk of developing cardiovascular disease. And across these studies, it really suggests that unhealthy behaviors and health conditions really play a role in that link. So factors like smoking, poor diet quality, physical inactivity and weight, for example, overweight or obese status, as well as other mental health conditions like depression, anxiety, and substance misuse. These all together explain part of that association for why we see that PTSD is predicting onset of cardiovascular disease. So thank you so much for this opportunity to share some of the work that we've been doing in my lab, as well as to share some of the information on traumatic stress and its implications for health. And so now I'm delighted to have a little bit of a chat with Dr. Ng. And then after our conversation, she'll go on to be focusing on the impact of traumatic stress with an eye toward understanding implications for treatment.
Great, wonderful. Thank you, Dr. Sumner. Always a pleasure to hear about your research and to see you present. So she knows me, and she always knows sort of my natural next question is always, well, what can we do? What should we do? How should we think about intervening if there are these links between trauma exposure and health outcomes, cardiovascular disease, PTSD, and those same health outcomes?
Yeah, I mean, I think one of the kind of next questions with thinking about an intervention perspective is how can we integrate physical and mental health care within a given setting and really appreciate, for example, in a mental health care setting, that there may be increased risk of cardiovascular disease among individuals who are presenting for treatment for PTSD. So whether that involves, for example, maybe, tracking different cardiovascular risk markers like, hypertension, blood pressure, lipid levels, looking at physical activity, smoking, and maybe in addition to working on addressing PTSD through mental health treatment, can we also potentially incorporate lifestyle interventions too? So thinking about, for example, promoting physical activity, is that a way that we can help to, potentially offset risk of developing cardiovascular disease and also maybe have some positive impacts for our mental health as well in that way. So I do think that this work, by demonstrating just how closely intertwined mental and physical health are after trauma, it really points to, I think, an approach of focusing on integrated intervention opportunities.
Yeah, no, wonderful. I completely agree. And I guess kind of going off of that idea, what do you make of this sort of bifurcation of physical health and mental health? Is that helpful, useful in any way? How should we think about that?
Yeah, I mean, I think that for so long, we've been treating things kind of above the neck as separate from things below the neck. And I think this work really shows us that we can't be doing that. And we're often, so siloed within different healthcare settings that I think it's kind of maybe lent itself to having this bifurcation in how we're talking about things. But, I think it really speaks to, again, the importance of integrated mental and physical healthcare and how can we, from both healthcare professional sides, but also as individuals presenting to healthcare settings, how can we take that appreciation of this close connection and try to use it to inform care and how we're going about approaching treatments?
Wonderful, great. Well, thank you so much. I'm sure that others have questions for you, which we'll be answering at the end, but I get to ask the first ones. And so now I'll move on. I think that's a nice segue into sort of intervention portion. Let me share here. Okay, so hopefully everyone can see that. So yes, thank you all for coming. It's always a pleasure to talk with Dr. Sumner and again, learn about her work and think about how we can tailor our research to have actionable outcomes for individuals experiencing traumatic stress. So this sort of second half of our talk, I'll be thinking about implications for treatment specifically, as well as sort of prevention of traumatic events in general and traumatic stress health outcomes after experiencing traumatic events. So one thing that I'd like to start with is thinking about multiple levels of intervention. Often when we think about intervening or doing something to reduce poor health outcomes after trauma, we often think about sort of the individual level. So psychotherapy, which I will touch upon, but there are a lot of other levels of intervention that we should take into account when we think about, good health outcomes after traumatic stress. So just to draw your attention to sort of the society and community level of intervention, societies that are perhaps more healthy are ones that have fewer of these things on that I have here. So structural disadvantage, prejudice, discrimination, communal traumas, for example, like wars that the whole population may be exposed to, concentrated poverty or neighborhood dangers, and also communities that either lack completely or have lower resource or unsafe community services or resources are going to put people at higher risk of both experiencing traumatic events in general and also having poor health outcomes after experiencing those events. So these types of factors induce a lot of chronic stress on individuals, which then exacerbates outcomes of trauma. And so the level of society and community is critical when we think about intervening in mental health for people experiencing adversity. The sort of second layer I want to think about is relationships. So social support and positive relationships play a critical role in sort of intervention for trauma. So sort of natural and formal supports that people have, positive relationship supports, positive parenting go a long way to buffering the effects of traumatic stress. And conversely, relationship conflicts that people experience actually exacerbate risks of poor outcomes. So intervening at the relationship level is also a really important component of understanding how people sort of recover from trauma events. And now I'll get down to the individual level, which, as I said, is typically the level that people think about when they think about sort of intervention. And, you know, we're all different. You know, we all have different backgrounds, different experiences, and different factors like genetics, like mental and physical health history, like aspects of the trauma exposure itself, play a differential role in sort of their toxicity of leading to poorer outcomes. And so usually these types of factors predate the trauma exposure. And so we often think of these as sort of less modifiable factors, things that we wouldn't typically intervene on per se when thinking about helping someone recover from trauma exposure. Things that are more modifiable are things like, for example, autonomic nervous system reactivity. So I have this picture here of the baby. Autonomic nervous system reactivity is generally sort of our general set point of how we react to the environment. Are we someone who is very reactive to environmental stress, or someone who's sort of naturally maybe a little less reactive? But that level of reactivity can also be associated with different health outcomes. So higher reactivity is typically associated with poorer health outcomes. But this autonomic nervous system reactivity can be influenced by therapies and interventions. In addition, kind of our behavior, so what we do, as well as our thoughts, so what do we think about and how do we think about things, has a big impact on how we sort of, how our physical and mental health manifest after experiencing traumatic events. And perhaps not surprisingly, therapies for PTSD really lean into those differences. So this is just a snapshot of some names of psychotherapies for PTSD, not all of them, but some of them. But just to give you a sense of, just in the name itself, you can see some clear patterns. So cognitive shows up a lot. So the way that we think about the trauma event itself, the way we think about ourselves or the world after experiencing the traumatic event. Behavior, so again, what we do after experiencing a traumatic event and what we do in our day-to-day life has a big impact on our outcomes. And finally, exposure. And here they're talking about exposure to the traumatic event itself. And this could be in sort of the way exposing yourself to memories of the trauma or talking about the trauma, maybe in more detail than you have in the past, or maybe even doing things that expose you to reminders of the traumatic event. All of those things go a long way towards improving your mental health and physical health after experiencing a traumatic event. So that's all well and good, assuming that you can get access to treatment that you are seeking. And lack of access is a huge problem for mental health, and trauma is not specific to that. But I just want to draw your attention to what we talk about when we talk about lack of access to treatment. This is a map at the county level from 2020 of mental health shortages. And just to orient you, the darker colors are counties that have fewer mental health providers than are needed for the population that's there. And this very light blue color are counties that are thought to have potentially enough mental health providers to actually treat the needs of the individuals living in that community. And so you'll see very few light blue patches and mostly all dark blue patches. And actually about 55% of US counties don't have a single psychologist, psychiatrist, or social worker available who's trained in mental health treatment to actually deliver care to the population. And so perhaps not surprisingly, the median time from symptom onset to first treatment for individuals here in the United States is about 11 years. So people are living with untreated mental health symptoms that are contributing to a whole host of poor outcomes, as Dr. Sumner just mentioned, some of them being physical health outcomes and leading to potentially higher mortality. So one of the things that we've been thinking about in our lab is different novel or innovative ways to get care to more people. So although most of counties don't actually have specialized mental health services available, most of them do have primary care available. And when people think about healthcare services, they often think about the primary care doctor that you might go to if you have the flu or you need a vaccine, for example. And so one of the things we're trying to consider is what would PTSD treatment look like in that context, so delivered in primary care. And we've been specifically focused on adolescents, in part because that about 7% of US adolescents are thought to have PTSD by the time they turn 18 years old. So a lot of people who are going to experience PTSD already have it early in life, and early intervention is critical for better health outcomes. When we look at those adolescents who are receiving health services in what we call sort of safety net hospitals or safety net health centers, so these are adolescents who may be, for example, utilizing Medi-Cal or Medicaid services and are perhaps lower income or lower resource, about 30 to 50% of them are thought to actually have PTSD. And almost all of them are not getting identified and not getting treatment. But they also tend to go to primary care if only to be able to, get the doctor's note to register in school. And so this is potentially an opportunity to reach these youth and have early intervention for them. And so that's actually what we've been doing in our lab here in Los Angeles, is thinking about this sort of primary care-based intervention for PTSD delivered in the doctor's office by integrated care providers. And we found in our initial preliminary work improvements in PTSD, anxiety, depression, and substance use symptoms in only 3 sessions. So these are sort of by need, short treatments because they need to be integrated within the what's actually feasible for primary care. But we are finding good outcomes thus far, and we're continuing to do that work. So thank you all so much. I'll wrap up there. There's always more to talk about, but I think we'll cover some in the Q&A.
Great. Thank you so much, Dr. Ng, for, I think it's so important to really think when you are approaching intervention and, really appreciating the different levels of opportunity for intervention and also just different factors that may impact individuals' responses after trauma. And so just kind of really leading with that, I think is such a good reminder for all of us. So thank you. I really found the statistics about lack of access to care that you presented. It's just so staggering and really sobering. And I'm wondering if you could identify maybe one barrier that you could remove that, would hopefully provide more access to care. What do you think that would be?
I mean, honestly, like getting more providers available. There's a lot of barriers that people experience, but there are a lot of people who are actually seeking care, who are currently trying to find treatment for themselves or loved ones who are really struggling with being able to, get off of a wait list, for example, or find someone to provide care who's affordable for them and their family. And so having the available numbers of providers who are trained in these treatments, who are available in the community, so not an hour's drive away. I mean, if I could wave a magic wand and change sort of health service delivery, I think that would be it, to have available providers who are affordable for individuals and when they want it. So not with the wait list of 6 months, for example.
Definitely. No, that's such a good point there. And another thought that came up when you mentioned about, having providers accessible within, like, say, driving distance or something close by, it does seem like with COVID-19, perhaps one of the maybe potential, silver linings could potentially be the kind of increased kind of access or use of telemedicine. And so I just wonder, to what extent you think that might that increased availability of telemedicine, could that, impact, traumatic stress treatment? And are there any also concerns, though, to maybe think about on that front too?
Yeah, I think that availability of telehealth is actually one of the few silver linings that came out of the pandemic. Prior to the pandemic, most therapists were not allowed by insurance policies or licensing boards to provide therapy through telehealth. And now with this, because we had to all immediately shift and that became the standard of care for 2 years, we're seeing very good outcomes of telehealth for a number of different people. And I think it's here to stay. And it does offer the opportunity for people who otherwise wouldn't be able to access care because of sort of location, logistics, getting off in the middle of the day, to have that option to get care. And it also allows providers who, for example, are sitting here in Los Angeles to provide care to someone in maybe a more rural area of California, which is huge. I think that it's not a panacea. It won't solve everything. There's a number of people who would prefer and would benefit from in-person care. And so that still does need to be available. In addition, there's, as we all know, there's lots of technological challenges that people face with broadband and computers and, phones acting out. And so, all of that needs to also be addressed, and it disproportionately impacts, people who may not have access to those resources, or maybe are older adults or don't have, someone to assist them with getting all of those things set up. So I think that, it's not everything, but it is the step to getting more people more access.
And if you could think of it maybe as like one more tool in the toolbox in terms of trying to increase access, then that's something that, we'll definitely embrace in that way for sure.
Exactly.
Yeah. Great. So now, would you like to maybe open it up more broadly for kind of questions from attendees?
Okay, good deal. There are lots of questions, and so I'm very happy to pose them for the audience. Thank you first for these, for your conversation and for your knowledge, for sharing that with us tonight. Okay, so let's start with a question. And this actually goes to both of you because Dr. Ng, you mentioned the autonomic nervous system in your talk. And Dr. Sumner, you really also try to understand sort of the biopsychosocial mechanisms. You mentioned the behavioral mechanisms that may make that link between PTSD and CVD. We have a question about what about the association between trauma and heart rate variability? And particularly sort of that resting heart rate variability and the resilience that has been written about that actually, well, first, let me ask you to tell the audience what heart rate variability is. And second, is there any evidence for that being important in the link between PTSD and CVD or other health outcomes?
Yeah, so I think that's a great point, and we definitely think that it's a relevant factor and something it is that we're measuring in our work. So heart rate variability is kind of unpacking that term of kind of how much variability is there in the spacing between your heartbeats. And so sometimes we want to be able to see this kind of greater variability as an opportunity for kind of sort of greater flexibility of response of our autonomic nervous system, which is one of our kind of biological stress response systems. And so we are interested in this idea of kind of autonomic imbalance. So kind of not having that great deal of variability as a potential mechanism linking experiences of trauma and PTSD with cardiovascular disease risk. So we have our psychophysiology set up in the lab here at UCLA where we do measure heart rate variability, and we're interested in seeing to what extent that might explain why we see associations between PTSD and early cardiovascular risk markers.
Yeah, no, that's wonderful. And I think, to your question about intervention with respect to heart rate variability and generally about arousal, in PTSD, we actually sort of see this bimodal distribution, or some people seem to have over responsive arousal systems, and then some people seem to have under responsive arousal systems. But generally, as Dr. Sumner mentioned, the goal is to have what we consider a regulated arousal system, the ability to respond appropriately to stressors. And some, then that mechanistic pathway may be potentially sort of a cognitive one. Are you appraising situations as potentially being more dangerous, right, than they may appear to other people? And so your system kind of responds in that way, and appears unregulated. Or generally, is your baseline now a little bit more responsive or a little bit less responsive than what other people who haven't gone through the same events have experienced? But certainly in those treatments, there are aspects that are specifically designed to try to help you with that regulation. So for example, like relaxation or breathing techniques.
Great, thank you. Here's another question, but also pertaining to CVD, and the questioner was specifically interested in women. And so how high is the risk for, one, trauma in women in underrepresented communities? How high is the risk for CVD in underrepresented communities? And is the link between them different for example, Black American women versus non-Latina white women?
I think this is, such a great point to be raising in this appreciation of kind of stacked or overlapping kind of risk compiling upon each other when thinking about consequences for our physical and cardiovascular health. So we do see that trauma rates differ across, different settings, affect individuals from different racial and ethnic backgrounds in different ways, with individuals from more minoritized groups, unfortunately, often experiencing higher rates of trauma exposure. So as the questioner pointed out, we do see that uneven distribution there in terms of trauma exposure patterning. And then we also see that there are differences in cardiovascular disease rates. Again, unfortunately, seeing, for example, that Black women have an especially high risk of developing cardiovascular disease, say, compared to a white non-Hispanic women. And so if we think about kind of greater potential exposure to our predictor trauma, and then also greater underlying risks for cardiovascular disease in these individuals, then we can see sort of this kind of cascading effect of risk factors. And so it's really important to be doing work in diverse samples so we can understand these risks and then also figure out how we can best try to offset those risks.
Great, thank you. Here's a question, I think primarily for Dr. Ng. What might a trauma intervention at the relationship level look like?
Yeah, that is a great question. And I think that it would speak to this idea of how do you have positive, supportive relationships, as well as how do you improve communication, let's say, and if it's a couple, for example, coming in and one individual, let's say, has PTSD, and perhaps the other one does as well or doesn't, but is helping to support the individual who might be having that, is to be able to, for both individuals to learn about what trauma is, what PTSD is, what the sort of symptoms are, how best to cope together sort of as a dyad when faced with those stressors, and learning strategies about how to sort of think about and talk about the trauma. So that I think that the communication piece, I mean, trauma in individual treatment itself really focuses on the communication around the trauma and exposure to traumatic events. But when you have a supportive other there as well, the ability to work together to share and disclose and talk about trauma, maybe even more enhanced. And so I think that there's a lot of potential for relationship level treatments, and that is actually being done right now, particularly at the VA level, the Veterans Administration hospitals, to look at couples levels interventions for trauma. And thinking about, how can the relationship itself, independent of the trauma, be improved, sort of general couples relationship counseling, because that alone, if that is improved, will go a long way to improving outcomes for both individuals.
Great. And this is a sort of follow up on that. You know, we've talked a little bit about individual. We're now talking about the relationship. But one of our guests said, you spoke about taking a systemic approach to trauma, which the guest said, I greatly appreciate and believe in wholeheartedly. So are there truly systemic treatment models emerging or systemic prevention models emerging for PTSD or other kind of stress-related disorders?
There are, I would say, at the organizational level. So things like trauma-informed care really came out of sort of health organizations thinking about how to provide services in a way that would be the most safe, you know, provide the most autonomy and justice to individuals, be the most clear for individuals who had experienced traumatic stress and may understandably be very wary of different organizations. And so those sort of principles have been, they've tried to apply those in health settings and in some cases in educational settings as well, to have practices that really promote a sense of safety, autonomy, and well-being for individuals. In addition, a lot of sort of trauma-facing organizations really pay attention to sort of wellness, for example, for staff and individuals working in those settings, paying attention to things like, what does the room look like? Is it a nice and warm and safe environment that we're bringing people into when we ask them to participate in these kinds of trauma therapies? So I think that it is there. I think it is not the norm, but I think that particularly for organizations that are aware, have some awareness of the trauma exposures their beneficiaries and the people they work with and work in the organizations maybe facing are trying to move that way. But I would love to see it permeate all of society and all levels. So I think it's and you know, there's some sort of restorative justice approaches, for example, in education settings that also have this eye to being more trauma responsive.
This also makes me think of your research around the globe and to collectives exposed to trauma. Can you talk a little bit about a systemic approach in that case, and what are you trying to do, and what are country mental health systems trying to do when you're talking about trauma exposed to a collection of people?
Yeah, I mean, when we think about sort of community level trauma, I think there's a number of different factors, right, that go into that sort of what was the original trauma to begin with. Was there a particular group, for example, targeted? Was the entire community affected? But again, I think being very open about those issues and allowing that conversation, encouraging that conversation to take place, while also addressing the fact that when communal violence, for example, a war or genocide takes place, it's not just the individuals impacted. Typically, the community resources like hospitals, like schools, like playgrounds are also destroyed and decimated. Places of healing, religious spaces get destroyed as well. And that can be just as devastating, if not more so, over the long term for the community, when those things are not available, when you can't send your kids to school, when you can't get a job, you know, when you can't worship in the way that you used to. And so any emphasis on restoring those spaces where there was safety, where there was community, which allowed, and places that allowed people to earn a living, for example, are critical to thinking about healing. Without those in place, the individual level interventions are effective. It's not that they're not, but they're very small in scope compared to the broader societal impacts.
Thank you. And this is a question for both of you, actually from one of our Department of Psychology Board of Advisors. So it's great to see you or to know that you're there. And the question is, have you looked at trauma outside of the PTSD diagnosis? And you know, people talk about small t and big T trauma. And then I'll ask a follow-up from our Board of Advisor member.
Yeah, I mean, I guess just to start off the response to this, I think it's important to appreciate a wide range of experiences that people go through. Yes, there's a certain type of traumatic experience that would meet, criteria for potentially triggering post-traumatic stress disorder, like the events I discussed at the beginning of the session. But there are also other experiences that maybe wouldn't always fall within that classification that we also see have major impacts on mental and also physical health. So for example, like there's some experiences of discrimination where maybe it wouldn't meet that threshold for a criterion A trauma, but we see that that can have huge effects on both mental and physical health. And so by really kind of broadening, I think, our appreciation of the impact of the range of experiences that can be had, I think we really will ultimately develop more comprehensive models of understanding how the factors that influence people's health.
Okay. And have either of you looked at, or do you know about anything about the interaction between trauma and people who, they're often called highly sensitive persons? So people who are particularly sensitive to environmental stimuli, et cetera.
Yeah, so I mean, there are definitely individual differences in sort of reactivity or responsiveness to the environment or to environmental stressors. And all of those individual differences do play a role in how people sort of respond and react to all events, not just trauma. But for example, you could have 10 people in a room and they all sort of experience the same event, and they all will have different reactions to that, interpret it in different ways, and have different sort of mental and physical health outcomes. So someone who already knows themselves as someone who is very sensitive to environmental stimuli may have a very strong reaction to that event, whereas someone else who maybe naturally knows themselves as not sort of particularly responsive to events may not have that immediate reaction. I also think it's important to know that reactions change over time and symptoms don't develop immediately for many people. And also an immediate reaction to an event doesn't actually mean that you're going to go on to develop post-traumatic stress disorder. In fact, the definition of the disorder requires the symptoms have been present for at least a month, if not much longer. And so it's expected that within that initial sort of reactive period, that people will have a reaction. That's the natural response to trauma. So I think, also not necessarily thinking of it as potentially a problem, maybe just more of an individual difference.
Thank you. And so here's another question. Is there a difference in effectiveness between online therapy for PTSD versus in-person therapy?
So telehealth-based therapy, I'm going to assume that this is telehealth.
Yeah, why don't you say what telehealth is, and then what do you know about any difference in effectiveness?
Yeah, so telehealth therapy is essentially getting the same types of treatment or components of treatment that you would get in face-to-face. So when you're sitting in the same office, for example, except for now you're getting therapy delivered by video. So you are working with someone who's a trained provider, and they are sort of providing the therapy through the video. I mean, there are adaptations that have to be made with telehealth. For example, if you're someone who uses worksheets and you typically work with the patient or the client to work on those worksheets together, it might look different sharing that on a screen versus working on it together. So there are some differences to adaptation, but the effects look very good. I mean, again, it's sort of relatively new compared to our much longer time horizon of understanding treatment outcomes for in-person therapy. But thus far, the effects look pretty good and fairly comparable for most people who want telehealth therapy and can engage in it.
Right, thank you. And I know neither of you work in this area, but what about pharmacologic treatments for PTSD, and both in terms of access to those and in terms of effectiveness of those compared to the other evidence-based treatments that are more cognitive, more behavioral, more emotional?
I can do this.
Sounds good, yeah.
Okay. So yeah, it's a sort of yes and sort of answer, because there's no identified pharmacological treatments that seem to have a specific effect on PTSD symptoms. However, there are a lot of comorbid symptoms that come along with PTSD, like depression symptoms, like anxiety symptoms, like sleep symptoms, that are positively impacted by medications, for example, like SSRIs, for example, which would be sort of standard treatment for depression or anxiety. For someone with PTSD who's prescribed SSRIs, they probably would see a good impact, particularly for symptoms like negative thoughts and moods, difficulty sleeping, difficulty sort of getting themselves going in the morning. But for some of the other PTSD symptoms, they may not see as much of a change. So it's sort of maybe very helpful, but may not be sufficient. And so we do suggest that the psychotherapy be incorporated to address those other PTSD symptoms. Sort of those consistently seem to have better outcomes in the long run for people. But I also would say, for sure, don't, if you have access to SSRIs, for example, or I'm not a psychiatrist, I'm not going to, recommend medications, but it's definitely worth a conversation with your provider or physician about that.
Great. I'm going to follow up with one more with you, Lauren. And a couple of people have asked what specific intervention or what were the kinds of interventions that are provided at the primary care level with adolescents?
Yeah, so we, in our sort of brief treatment, we have a few different main things. One is what we call breathing retraining, which is actually learning to breathe in a different way that will promote lower sort of reactivity, lower arousal. So it provides the adolescent with a tool that they can use anytime, anywhere to actually reduce their own sort of physiological stress. And when someone is less physically stressed, they're then usually more emotionally available and calmer. So that's one thing that we teach. We also do a lot about psychoeducation. So information about sort of what is trauma exposure? What are some of the common reactions to traumatic events? And that's not just with PTSD symptoms, for example, but also things like substance misuse or difficulties with relationships or more difficulties in school. So providing that information does a number of things we hypothesize. For example, we think it might reduce stigma, it might increase motivation for treatment, it might correct some perhaps inaccurate beliefs that some of the youth might have. For example, they might think, oh, I'm just a bad student, or I just can't get along with people, or I'm just a bad kid because I always am, angry and irritable. And they learn that actually that is a symptom of trauma and makes a lot of sense given what they've gone through. And then we also teach coping skills, and we try to tailor those coping skills to the symptoms that the youth have. So some youth, for example, may be having a lot of difficulty with memories popping up into their mind when they don't want them to, or difficulties sleeping or concentrating, or maybe they're having difficulties avoiding things or trying to push thoughts aside that they don't want to have. And so we tailor coping skills to the youth to help them be able to address those symptoms and be more functional and do the things that they want to do.
Fantastic. And here's one I think that's probably a little bit more for you, Dr. Sumner. So what's the role of sleep? We know from the research done in this department and many others that sleep is more important in just about every outcome. So what's the role of sleep in that link between PTSD and cardiovascular disease or other physical health outcomes?
Yeah, so we see sleep, as you were just alluding to, is like pivotal, really. So it's often the most commonly reported complaint that individuals present to a healthcare professional with when they have PTSD, either the nightmares that are keeping them from being able to get a full night's sleep, or just not getting to be able to fall asleep easily, waking up and not being able to fall back to sleep, waking up too early. Sleep difficulties are common and understandably really distressing for many individuals with PTSD. And so not only is that a symptom of PTSD, but it's something that can also contribute to increased risk for cardiovascular disease. So poor sleep is definitely related in studies to increased risk of developing cardiovascular disease. But in my lab, working with one of my students, we actually just did a recent review because we think it's a really important mechanism linking PTSD with cardiovascular disease risk, but we could not find studies that are actually testing that full pathway. There's a lot of research demonstrating that sleep is impaired in individuals with PTSD, that sleep's related to cardiovascular disease risk, but we weren't able to really be able to find that work out there in the field. So we really kind of put forward this call to action of actually studying fully the extent to which sleep may kind of be that linking pathway between PTSD and cardiovascular disease. And so in some of the work that we're doing in the lab now, we are at least beginning with some self-report measures of sleep in our individuals who've been exposed to trauma who are coming in from the community for studies.
Great. I think we have a minute, maybe a minute or two more for questions. And here's one from someone who is going to be a future mental health professional. And how can mental health professionals stave off conditions such as empathy fatigue, and do things like empathy fatigue in healthcare professionals? Does that also have a connection with CVD or other kinds of both psychological and health outcomes?
Yeah, I mean, I think, it's really important as healthcare providers to be thinking about also providing care for yourself, especially when, doing care with individuals who've been exposed to trauma and hearing about these stories. It can be taxing potentially. And so it's so important to be devoting time to making sure that you're being able to have your network to process these stories with, that you're doing things in your day-to-day that really help to promote your sense of being grounded and being able to take time off in that sense. We see that kind of physician burnout sort of kind of more broadly in like a healthcare setting is associated with some adverse physical health outcomes. We see even something like not being able to focus as clearly in terms of cognitive function impairment when there's kind of this sense of burnout and overwork there. So I'm not quite sure about the extent to which it's also been linked to cardiovascular disease onset, but we can definitely appreciate that level of kind of psychological impact can also have physical health impacts too.
Lauren, I know you have worked with mental health professionals, both locally, but also internationally. What have you learned in terms of supporting mental health professionals?
Yeah, I mean, I think it's so critical to have a team and to have a place to either have peer supervision or sort of formal supervision, to be able to, yes, process these experiences and the challenges that come with hearing about difficult events. Oftentimes providers feel like helpless, or they really wish that they could change a situation, but they can't. And having your professional network be able to support you through that and help you understand sort of what's your role and to feel confident and comfortable in that is so critical. But the burnout is real. And when I was a trainee in supervision, I got to the point where I was thinking that all children were abused. I just would hear a kid cry and I would think, oh, something is wrong. There must be being traumatized, because I was working constantly with youth who were experiencing trauma. And my supervisor told me, this weekend, I want you to go to the playground and watch the kids play and realize like most children are actually fine and happy and in healthy environments. And so sometimes you can get tunnel vision very easily. And so having that network is so critical.
I want to thank you both. This has been fascinating, and your research is so important. The three of us, speaking to the audience, the three of us get to go out to dinner and continue this conversation. And I wish you could come with us because the research is so exciting. This session has been recorded, and we will have a link available for you to view it. And again, thank you so much for joining us tonight. Stay tuned for our next psychology present. And thank you so much, professors. It's just been a fascinating conversation. Good night, everybody.
Thank you. Good night. Thank you.